Good evening, everybody. Thank you so much for joining our webinar. This is Dr. Michael Kettel, and I am Dr. Susanna Park. We're two of the physicians at San Diego Fertility Center. Thank you so much for taking the time this evening to talk about IUI versus IVF. So we want to take first a little bit of moment just to acknowledge that COVID really has been a challenge for all of us. And for those who have been affected by it health-wise, really our hearts go out to you. And during this challenging time, we, recognizing the importance of family building for all our patients, are pleased to let you know that we are performing all fertility medical treatments, including IUI, IVF, uterus tests, hysteroscopies, etc. And it is a relief to know that the latest studies have shown that there is no evidence of what we call vertical transmission, meaning infection from mom to baby while pregnant. So a little bit about San Diego Fertility Center. San Diego Fertility Center was created in 1989, and we are the third largest fertility center in the West Coast and the largest in San Diego. There are 5 physicians in this practice, and collectively, we have many years of experience under our belt. So with that in mind, we're going to start our presentation.
I just wanted to say welcome myself. Dr. Park is going to start the presentation and sort of introduce you to the concepts of what are important in human reproduction, and then the basics of doing IUI. And I'll be in the background, and then I'll talk a little bit about IVF, but we're going to have ample time to answer all of your questions.
Okay, so this first slide is a little bit about basic reproduction, which many times I have patients say to me, oh, I didn't learn this in school. Well, the truth is most of us did not. And we don't expect our patients to come in fully understanding how pregnancy works. But basically you have, this is the uterus, fallopian tube, and ovary. And you have an egg that grows from within the ovary, and one egg grows big to ovulate. Sperm, which comes from the vagina, which is down here, comes up through the uterus, through the fallopian tube, and meets the egg at the very end of the tube. A fertilized egg we call an embryo. The embryo meets with the sperm, and it takes about 5 days to make the journey back through the tube to stick in the uterus. So that is basic reproduction. And so we need to make sure that the basics are working, meaning that you have eggs, that the sperm is working, that the fallopian tube is open, and that the uterus, where the embryo will implant, is clear. So what goes on in the ovary? So unlike men who make sperm all the time until they die, women do not. Women are born with a finite number of eggs. And this picture here represents all the eggs that we're born with. And when we run out of those eggs is when we go through menopause. And it's a very common misconception that every month women just lose 1 egg. But it's actually a bit more complicated than that. What happens every month is from this finite egg supply, a group of eggs will come out. And that group has a name. It's called antral follicles. And without any fertility drugs, of these antral follicles, one will grow big to ovulate. And the rest of these antral follicles that weren't chosen to grow big and ovulate, they do not go back into your supply. They dissolve and become part of the ovary. However, if you give fertility drugs, you can prevent some of the eggs from dissolving such that you can have multiple eggs ovulating at the same time. So that's the idea behind how fertility drugs work. Many times people say to me, okay, I hope you give me enough fertility drugs so I can make 20 eggs grow big. But if your antral follicle consists of 10 follicles, then no matter how much drug we give you, we can't turn that into 20 because the fertility drugs only work with the cohort you already pulled out. Fertility drugs do not pull more eggs out into this cohort. You pull the cohort. Fertility drugs just try to get whatever's in this cohort to grow. And another common misconception I hear is people say to me, well, I don't want to do IVF because you're pulling out my future eggs. We're not, because the eggs in this cohort, if you don't use them that month, they are not going back into your supply. They are going to just die off. So understanding that, I'm going to talk about IUI, which stands for Intra-Uterine Insemination. So you have a choice. You can use no fertility drugs, which again means that your body naturally picks one egg to grow big and ovulate, or you can choose to use fertility drugs, which will get your antral follicles to grow such that you're ovulating more than one egg. There are two types of fertility drugs. You can use pills or you can use injections. And both of these will get more than one follicle to grow. And after you take these drugs for a few days, or if you do no fertility drugs, then we just monitor your cycle. But after a few days, you will be ready to ovulate. And to make sure that we get the timing of the IUI correct, we will trigger your ovulation with a drug called OVARY. And ovulation means that the egg will come out of the ovary into the fallopian tube. We then time the IUI to happen when you're ovulating. So for the IUI, sperm is brought to our center, we wash it, we concentrate it, and we place it inside the uterus. So here's a picture of the uterus, fallopian tubes, the ovaries. And that sperm is concentrated in a catheter. A speculum is placed inside the vagina like a pap smear. And a tiny catheter is inserted through the vagina, through the cervix, into the uterus. And many times patients ask me, well, why can't you put it at the end of the tube where the egg's coming out? And the catheters just don't reach that far. And then after you do the IUI, a couple weeks later, you do a pregnancy test to find out if it was successful or not. So there's some advantages and disadvantages to IUIs. The advantages, there's no surgical procedure. In addition, it increases the number of sperm that enters the uterus compared to sex. And it's very affordable. The disadvantage of IVF is that if you choose to take fertility drugs, you have the risk of more than one child, right? Because if you're ovulating more than one egg at the same time, we don't know that there's a possibility. We don't know if all of them will fertilize. And if the IUI is unsuccessful, it's difficult to know where things went wrong because we can't see inside your body. So maybe the sperm never even entered the fallopian tubes. Or maybe it did, but it just never found that egg. Or maybe it did find the egg, but it didn't fertilize. Or maybe it did fertilize, but the embryo just wasn't strong enough. And it passed back through the fallopian tubes, but it didn't stick in the uterus. So it's difficult to tell where things went wrong. So this is where IVF comes in. And Dr. Kettel will present the IVF portion.
So now it's my turn. So we're going to move on to the other alternative that we're contrasting in today's webinar and talk about IVF, and then we'll be comparing the two so that you can learn the differences between IUI and IVF, advantages of some and advantages of others. You're going to hear me use the word slide because Dr. Park is actually managing these slides from her computer. So go ahead and advance to the next slide. So Dr. Park introduced the concept of using fertility drugs to get the ovaries to produce more eggs. In a natural cycle, a single egg is grown to a dominant follicle and ovulated, and in IVF, that would not be desirable. We want to have many eggs in IVF because we're going to make some embryos and we want to get some good embryos. And the bigger the group of embryos, the better the chances are of having that perfect baby making embryo. So in IVF, there's always a combination of fertility drugs that are used to get the ovaries to produce many eggs. And these are the strong fertility drugs. They're not the pills that Dr. Park had alluded to. These are the injectable family of fertility drugs. And you start these fertility drugs in the beginning of your cycle, and you take those fertility drugs daily for about 10 to 12 days. Now, while you're doing those injections, we need to watch how the ovaries are responding to that medication and that stimulation by the fertility drugs. And you can see on this slide some pictures of ultrasounds, because that's the tool that we use to watch the follicles grow. On the left-hand panel, you see a picture of an ovary, but it has really just one big follicle in it, and then some little follicles that did not grow in that particular cycle. The right-hand panel, you see an ovary that's been stimulated with fertility drugs. And look how many little black circles there are. Many, many, many little black circles. And all those little black circles are called follicles, and each one of those follicles contains an egg. So in the fertility drug treatment, we're going to get the potential to retrieve multiple eggs. We also do some blood work to monitor your hormone levels along the way. So in IVF, we watch the follicles grow, and then ultimately we need to go get the eggs from the follicles. And this is where this minor surgical procedure takes place. We do have you administer an ovulation drug. It's a hormone called HCG that stimulates some of the maturational processes within the eggs. And then we intervene before the eggs can be ovulated and go and retrieve the eggs in a very, very simple procedure. It is done in the operating room, and it's done under anesthesia because it would be uncomfortable without that. So an IVF is started and medication is given through the IV. You'll basically fall asleep, and then once you're comfortable, the eggs are retrieved vaginally, needle aspiration of the follicles, but there's no abdominal incision and no scars. So the procedure doesn't take very long, maybe 15 to 30 minutes to aspirate all those follicles, collect the follicular fluid and the eggs, and then hand those little test tubes that we collect into the embryology lab. Next slide. And this is a picture of what that oocyte retrieval looks like. So some people think that we go through the vagina, through the cervix, up and around the fallopian tubes, and then all the way out to the ovaries. And it's not really done that way. This is a good picture of what the process really looks like. And that you can see a probe, a vaginal ultrasound probe at the bottom of the screen. So that's been inserted vaginally into the corner of the vagina and the cervix. And then there's a needle guide that's attached to that ultrasound probe. And now we can see on the ultrasound machine where the follicles are. And there's a little needle guide. It's a dotted line that shows up on the screen. That's a computerized merge of the ultrasound image and where the needle is going to go. So we line up this needle guide, this biopsy guide, and then we advance the needle into a follicle and then press a button on the floor that activates a suction pump and suck out the follicular fluid into a collection tube. The egg is in there, but we can't see the egg because eggs are microscopic. So we collect the follicular fluid into a series of tubes, test tubes, and then the test tubes are handed to an embryologist in a room next door in the laboratory, and they will pour that fluid into a petri dish and look under the microscope and then find the egg as a single cell microscopic structure within that follicular fluid. And the physician will just be serially going through all those follicles, aspirating all those follicles and collecting all those eggs. This is all done while you're asleep, so you won't be feeling anything. After the procedure is done, you'll recover in the recovery room for a few minutes. Now this is a video, and we're going to be playing it in the background, but you can see the needle coming from the very top of the ultrasound. It's what's wiggling right there. And that needle is going into a follicle, and then the follicle is going to collapse around the needle. And that's the follicular fluid being aspirated into a test tube. And you can see that you're just going from one follicle to the next, aspirating the follicular fluid, collecting the follicular fluid into a series of test tubes, and those test tubes are then handed through a pass-through window into the IVF laboratory, and the embryologists are giving us minute-to-minute feedback. So they're telling us, you know, we have 1 egg, we have now 3 eggs, we have 4 eggs as we're aspirating the fluid, and then they're identifying the eggs within the follicular fluid. And we'll just continue going until all the follicles are aspirated. Now, the video that you just saw was a pretty nice IVF cycle, because you can see there's lots of follicles in there. And that would be wonderful if we had that many follicles to work with, because that's going to give us an opportunity to get many, many eggs. But that's not always the case. And some women aren't capable of producing that many follicles. That's reflected in the antral follicle count that Dr. Park was alluding to. As women get older, the number of follicles decreases. That's a normal consequence of reproductive aging. And we may be only able to achieve 3 eggs or 5 eggs or 10 eggs or whatever it might be. Even though it would be really nice to get 20, we may not be capable of getting 20 eggs. So once the egg is provided to the laboratory, the next part of this we need is sperm. And in most cases, the woman's partner will produce a sperm sample on the same day that the eggs are retrieved. There are other ways to work around this under special circumstances. Sometimes we have partners that are deployed in the military or other reasons why they may have had to freeze sperm ahead of time, but we need sperm on the day that the eggs are retrieved, because that day is a special day, and that day is when the eggs need to be fertilized with sperm. So once the egg and sperm are successfully returned to the laboratory, then the embryologist will fertilize the eggs by manually inserting under a very high power microscope 1 sperm into 1 egg. It's a procedure that's called ICSI, ICSI, intracytoplasmic sperm injection, where we manually select the best sperm, and then that sperm is injected into each egg. You can see on this slide a comparison between how fertilization might take place under more natural circumstances and how fertilization would take place in an IVF laboratory. So the left-hand side shows an egg in the center of the slide, and it's surrounded by dozens of sperm. And those dozens of sperm are binding to the shell of the egg, and they're competing to get through that zona pellucida, that shell, to get into the egg. But you can see that there is a robust competition of sperm that are trying to enter the egg. On the right-hand panel, you have a high-powered view of an egg being held by a specialty pipette on the left side adjacent to the egg, and then a tiny little injection needle on the right-hand side, which is being advanced through the shell and directly into the cytoplasm of the egg. That's intracytoplasmic sperm injection, ICSI. And that's what we use to fertilize each egg. You can see on this slide a video of many sperm that are in a specialty collection dish in a droplet of media under oil, and a pipette that's now trying to pick up 1 sperm. There it goes. So that sperm successfully got into that injection pipette, and now that injection pipette can be moved over to where the egg is situated, and then the injection pipette can be placed into the egg, and the sperm then is injected into the cytoplasm of the egg. So now the holding pipette is stabilizing the egg, and now the injection pipette is coming into the screen, and you can see the sperm moving into the end of that injection pipette, and then they're going to now pierce the shell of the egg, go into the cytoplasm of the egg. There's a membrane there that they need to get through. There it goes. And now once that injection pipette is inside the cytoplasm of the egg, now you can, if you have sharp eyes, you'll be able to see the sperm be injected into that cytoplasm of the egg. There it goes. So now the injection pipette is removed. That egg is now fertilized with sperm, and it can now be cultured overnight to see if it successfully joins the 2 sets of chromosomes. That's called ICSI. So once we have fertilized the egg, we can observe that event in the laboratory the following day. And you can see on the bottom of this slide 5 images of embryos. We're going to start from the left and move to the right. On the left-hand side is an embryo that is just 1 day old. And you see 2 little orbs, 2 little spheres inside what was at one point an unfertilized egg. But now it's fertilized, and you have 2 what are called pronuclei. They are the chromosome packets of the egg and the chromosome packets of the sperm, and now they are ready to condense together. So that is a successful fertilization event of that egg. The imaging and the presence of 2 pronuclei indicate that that egg has successfully fertilized. From a group of eggs, fertilization doesn't happen in every egg. So maybe 70% of eggs will fertilize, but not every egg. That's normal. So the fertilized eggs, now called embryos, are cultured in the laboratory for 5 days. And now we'll move to the second panel as we move 1 panel to the right, and you can see 4 cells. So now that 1 cell egg successfully fertilized into an embryo has now divided into 4 cells. Those cells will then divide again. And the third panel over now shows an 8-cell embryo. So they've divided 1 more time. And this would be an embryo characteristically seen on embryology laboratory day 3. So about a 3-day culture event is going to lead to a multi-cell embryo, successfully undergoing mitosis that we learned about in high school biology and dividing their cells as the embryo grows. The next step over is what's called a morula. This is the beginning of forming a blastocyst embryo. And you can see that those distinct 8 cells are no longer distinct. It looks like a big mush. And that's when these cells are coalescing into this structure called a morula. And then they're going to expand out the next day into a blastocyst embryo. And that's the image on the far right-hand side. And that blastocyst embryo is now successfully fertilized into its unique chromosomal individuality that makes every one of us different from the other. And you can see that there's a lot of cells in there. Now this is under different magnification, but there's an outer rim of cells in that blastocyst. That's called trophectoderm, and those are cells that are going to become the placenta. And then there's a little cluster of cells in the bottom there that's inside the blastocyst, and that little cluster of cells is called the inner cell mass, and that inner cell mass are cells that are destined to become the baby. So now that blastocyst represents the first stage where cells are going to take on specific and unique functions. Some cells are now destined to become placenta, and some cells are destined to become baby. So that blastocyst is now ready to implant. So we culture those in the laboratory for 5 days to reach the blastocyst stage of development. So now we're ready for the embryo transfer. And if you look at some similarities in the embryo transfer, it's kind of just like the IUI that Dr. Park was talking about. So the embryo transfer is an easy procedure. It does not require anesthesia. It's very much like what she was describing, where much like a pap smear, a tiny catheter is guided through the cervix, and then that catheter enters the uterine cavity, and then we can inject an embryo into the uterine cavity. That's called an embryo transfer. Now, more times than not, we're transferring a single embryo, but this is where we have some structure and control over the risk for multiples in pregnancy, twins, triplets, things like that. Now, I come from a vintage a little bit beyond Dr. Park's because I'm older than she is. And then when I was starting my career, we commonly put in 2 or 3, sometimes even 4 embryos. That's just no longer necessary because we're getting so much better at growing embryos and being able to select out the best embryos. So now, more often than not, we're transferring a single embryo so that when a pregnancy is achieved, it's a singleton pregnancy, and you're avoiding the risks and the complications that are associated with multiple pregnancies. But this is where that control element takes place. So sometimes there's rumors on the streets about how IVF always results in twins or always results in multiples, and that's simply no longer the case, because that's a decision that's actively made between the doctor and the patient. So the doctor and the patient will discuss this in detail and formulate a plan for how many embryos are to be transferred into the uterus. And again, can't emphasize enough, but more often than not, we're transferring a single embryo. So this is an ultrasound of an embryo transfer. It's a little bit difficult to understand if you don't do these every day, but there's a little white line that's jiggling in the middle, and that's what the catheter looks like, because we do these under ultrasound. So surrounding that catheter is the uterine cavity, and then surrounding the uterine cavity is the muscular wall of the uterus. So we can see that on ultrasound, and you can see the catheter advance into the uterine cavity. So the physician can see that in real time and place that catheter at the perfect spot where the lining is the thickest and where that embryo is going to have the best chance for implantation. You can see a successful transfer there as a little white speck. That's actually the air fluid that contains the embryo. So we know where the embryo starts its journey because we can see that on the ultrasound. So this is a successful transfer, an ultrasound guided successful transfer of an embryo. So IVF has differences between IUI. And probably the biggest difference is that first bulleted item. It's higher success rates. And we're going to get into that momentarily, but I'll go through this first. So transferring an embryo shortcuts a lot of the things that were necessary in generating a success with IUI. And Dr. Park had described how the sperm have to get from the uterus out to the ends of the tube to successfully find the egg, fertilize the egg into an embryo, and then that embryo has to make its journey back through the fallopian tube into the uterus to implant and initiate a pregnancy. Well, we've done those steps for you in an IVF cycle. So those are already done, and we know then that there's an embryo successfully in the uterus ready to implant. And that's reflected in success rates, tremendously higher success rates in IVF. If you were to want the shortest time to becoming pregnant, IVF can go very quickly. Many take a stepwise approach and do some IUIs first and then IVF. But if you go directly to IVF, that would have the highest success rates and the shortest time to become pregnant. And this becomes an important part of a consultation as women are getting older and time is no longer their friend. IVF was literally invented in the 70s and early 80s for women whose fallopian tubes were blocked. And so that was the genesis of developing this technology to bypass blocked fallopian tubes. But now we use it for many, many other things. We use it to overcome abnormal sperm because we can select the sperm for ICSI, for the sperm injection. We can test embryos to see if they're chromosomally normal. So we're dealing with genetically balanced, chromosomally balanced embryos. We can identify gender in that chromosome testing. For some couples, that's a very important part of selecting the embryo for transfer. For others, it's not so important. And we can minimize the risk of multiples because we can choose to transfer just a single embryo. In IUI cycles, as Dr. Park was describing the fertility drug combination, you may ovulate 2 or 3 eggs, and that is now uncontrollable. So IUI cycles actually have higher risks of multiples than IVF, because in IVF, we're more often than not transferring a single embryo. We also have various options in egg, sperm, and uterus. So you may have a couple in which the uterus is diseased or maybe needed to be removed or could have fibroids or scar tissue or a whole variety of problems. And that couple may need a surrogate, another woman to carry the baby because she has a uterus that doesn't have issues. Or you may need different sources of eggs or different sources of sperm based on various different things that are very individualized to the couple trying to conceive. But IVF gives us those options of using various egg and sperm and uterus combinations. Disadvantages of IVF is that it is a surgical procedure that does require anesthesia, and it does require a highly specialized laboratory with many different quality control mechanisms and highly purified air and all kinds of different ways that we have learned through the years to culture eggs and sperm, make good embryos, and be able to select out the best embryos. And that all adds to the cost of the procedure. The IVF laboratory is $1 million adventure. It takes money and equipment to make that IVF laboratory work and to sing its song in making the best embryos that we can possibly get. So disadvantages are anesthesia, it is a minor surgical procedure for the egg retrieval, and the cost involved. Next slide. So that's the end of the formal presentation. We've now talked about IUI and we've talked about IVF, and I promised you a little bit of some insight into statistics because I think that's important in decision making. So understanding the statistics of reproduction goes back to, first of all, understanding what is normal human reproduction. And there's a classic experiment, it's been done many, many times, where 100 couples who want to get pregnant go out and try to conceive, and you follow up with those 100 couples a year later. And what you find is that a year later, 90 out of those 100 couples got pregnant. That's pretty good. But if you analyze that mathematically and you break it down into the chances of conception in each menstrual cycle, each ovulatory event, is not 90%, it's more like 20%. So 20% is what's often referred to as human cycle fecundity or cycle efficiency. And 20% per cycle is where we're stuck. Now, there are knowledge about cycle fecundities on lots of different animals in the animal kingdom. And I'll give you an example of a different animal. Let's take sheep for an example. And sheep have a cycle fecundity of about 95%. They're very good at getting pregnant, but they only ovulate once a year. They're called seasonal breeders. So they better be good at getting pregnant or there'd be no sheep, but we don't have a problem with that. So humans or women have a different ovulatory pattern. We ovulate frequently compared to different species in the animal kingdom. But our chances of conceiving each month that goes by may not be the highest. So when couples struggle to conceive, they may not be at that 20% per month range. It's probably going to be much lower. And a lot of couples are stuck in a cycle fecundity of maybe 5% per month because they may have all the parts. The woman is ovulating eggs, partner has sperm, uterus is normal and tubes are open, but they're just not getting pregnant. And after a year of trying, your chances of getting pregnant each month that goes by is no longer 20%, it's more like 5%. And what we need to do is raise that cycle fecundity. And that's what these treatments do. So Dr. Park had introduced the concept of IUIs, and IUIs do in fact increase the cycle fecundity by about double. So instead of now trying it on your own at home, you're trying with the IUI, and your chances of conceiving now have gone from 5 to 10%. Now you contrast that to IVF, and IVF now has already accomplished much of what's necessary in order for pregnancies to occur. So each time we transfer an embryo, even though it's just a single embryo, it can be a pregnancy rate of 60 plus, even as high as 70, 75%, depending on age and other factors. So 60 to 70% success versus 10% for IUI is a big difference. But the problem with IVF is expense, and it's sometimes difficult to get to IVF despite having that high success rate. So knowing what you need to know about the different choices can help the partners decide what's best for them. So I think at this point, what we can do is turn things over for any questions. Dr. Park, do you have any other comments?
No, I think that was absolutely thorough, comprehensive presentation. So if you have any questions, feel free to type them in. We see a couple here. So Dr. Kettel and I will just go back and forth and answer any questions.
Dr. Park, why don't you take the first one while I get these up on my computer screen?
Okie dokes. So the first one is, so it's two parts by the same person. I'm just going to answer the first question and then we'll just alternate. So the first question is, if you have blocked tubes, why don't you correct it through surgery? And that's a great question. So in the olden days, so I've been doing this 17 years, and in the very beginning, and Dr. Kettel and I, he remembers this, we would go to the operating room all the time to operate, right? We would fix fallopian tubes and ovaries and uteruses, and that's just sort of what our field was, a surgical field. However, as IVF has become more and more effective, you reach the point where you realize that, for example, fixing the fallopian tube, you can fix it, but the risk that the tube will block again was much higher than the likelihood of success through one IVF cycle. Because the question really is, well, why did those tubes block in the first place? And many times we honestly don't know. Sometimes we do know. Maybe the patient had a ruptured appendix. Maybe she had a history of an infection in the past. Maybe she has severe endometriosis. But unblocking that tube in and of itself isn't necessarily sufficient if you're not necessarily fixing the underlying problem. So, for example, if there was an infection in the past, it's called cilia, the little cells lining the fallopian tube, are damaged, and unblocking that tube, just making an anatomical opening, will unblock your tube, but the inside of the tube is still damaged, and so it's likely to reblock itself. So as the success rate of IVF has increased, your likelihood of success is much higher during an IVF cycle versus unblocking a fallopian tube. But it's certainly an option to be discussed with your physician.
I'll take the next question, which is, how do you know if a uterus is diseased? And that's part of the initial workup. So when a couple presents with infertility, there's some standard tests that need to be done. So the male partner needs a semen analysis to make sure that we've got sperm to work with. The female partner needs to have hormonal testing to look at if she's ovulating and if she has high quality eggs. But also we need to evaluate the uterus. So that's done with ultrasound and commonly in combination with an X-ray test that looks at the inside of the uterine cavity and the fallopian tubes. That test is called a hysterosalpingogram, or HSG. The ultrasound is going to be able to evaluate the muscular wall of the uterus and see if there's things like fibroids in there, or polyps or other things that would make it more difficult to conceive. So knowing that a uterus is diseased is certainly a critical part of the early diagnostic testing.
The next question is, what makes someone eligible for either IUI or IVF? So in order to do IUI, you must have at least one fallopian tube. And you must have sperm that after we wash it, process it, and concentrate it, in the perfect IUI world, we want there to be at least 10 million moving. So if you have a patient who has 2 blocked fallopian tubes, they are not eligible for an IUI. If you have a patient where the sperm before we process is, let's say, 5 million, can we do an IUI? Sure, but the truth is, by the time we finish processing that sperm, during which we lose a lot of sperm, there's not going to be much sperm, and the number doesn't get higher, it always gets lower. So we want that ideal sperm specimen to have 10 million moving sperm, and we're starting with less than that. Then after processing, it's only going to be a smaller number. However, if you have at least one open tube, and the sperm, while not perfect, is actually not bad, and your egg supply is not bad, then absolutely both options are available to you. And the way to make that decision, as Dr. Kettel alluded to earlier, is really a discussion of how impatient are you to become pregnant, how many kids do you want, how old is the egg source, how old is the sperm source. So there are many factors to take into consideration before you decide which is the right treatment.
So the next question is, what's the success rate for IVF in a normal 39-year-old woman? Well, it kind of depends on how you construct your IVF cycle. But in a 39-year-old woman, I would strongly recommend that she combine what's called PGT, or pre-implantation genetic testing, with her IVF cycle. because we want to make sure that we've got a genetically normal embryo to transfer. As women get older, the older egg struggles to fertilize normally. And at age 39, unfortunately but true, probably more embryos are abnormal than normal. So we need to, first of all, make sure we've got normal embryos to work with. Now, once we get to a normal embryo, that puts you in a wonderful place, because a genetically tested normal embryo in a 39-year-old works very well. Maybe not quite as well as in a 29-year-old, but pretty well. 60–65% of the time we transfer a genetically tested, genetically normal embryo, there'll be a successful pregnancy.
The next question is, can you do an IUI if you have a didelphys uterus? It's a great question. So let me first explain what didelphys is. So didelphys means you have two copies of, so there should only be one uterus, but because at the time the uterus was created, there should be two halves of the uterus that merge to become one uterus. Didelphys means that that merge did not happen, so that you have two parts of the uterus and they each have their own fallopian tube. And so the answer is yes. However, it needs to be an IUI without fertility drugs, because you do not want to be ovulating 2 or 3 eggs at the same time, such that you are at risk for having twins or triplets, right? With a didelphys uterus, you had higher risk for preterm delivery because the space in the uterus is smaller. So absolutely you can do an IUI with no fertility drugs. If you don't have regular cycles, then of course we'll give you fertility drugs, but the goal is 1 egg, and we consider that a successful response to the fertility drugs. Because if you don't have regular cycles, you don't even make 1 egg. So the goal would be 1 egg, whether you do it on your own or with fertility drugs, and then we do the IUI, putting it into the uterus on the same side where the egg is being ovulated from.
Next question is, if you bank embryos, how many are lost in the thaw? And the answer is not very many. So again, as IVF has improved, laboratory techniques have improved, their equipment has improved, the survival rate of a frozen embryo to be thawed, the survival rate is approximately 90%. So very few embryos are thawed, are lost in the thaw.
The next question is about how much is IVF and how long is the typical process of IVF from start to finish? So IVF, which in our clinic includes the monitoring for the IVF drugs, includes the anesthesia, the retrieval, and the transfer, is about $12,000. But separate from that, you have to pay a pharmacy for your IVF drugs. And that depends on how old you are, how many eggs you have. And that can range anywhere from $3,000 to $4,000 to as much as $8,000. So if you take all that into consideration, it's somewhere between $15,000 to $20,000, which is a lot of money. And there are some companies that do offer coverage for IVF treatment. For example, Starbucks does and Google does. And so it'd be good to look into your human resources to see if you have any type of coverage. And sometimes it's coverage just for testing. Sometimes it's coverage for testing and IUI. Or sometimes they'll cover IVF, but just give you a set amount. And it was how long is the process from start to finish? From the time you take your first IVF shot to the time we harvest, it's about 2 weeks. So it's pretty fast. But what takes so long is the preparatory phase, is making sure we teach you how do you do your injections and where do you order the drugs from, and did you get the drugs properly? Do you understand your calendar? And then to prep for the transfer, because we do those in 2 separate parts, the transfer is from the time you start your birth control pill, that's for 2 weeks, then you start estrogen tablets for about 2 weeks, and then you take progesterone for about a week, and then the transfer. So that's about a 5 to 6 week process.
Next question is, what's the average number of cycles required for a live birth in an average 39-year-old woman? And it depends. Hopefully just one cycle. So we would, retrieve a set of eggs, make a set of embryos. We had talked about doing genetic testing of these embryos, and 39-year-old women are different. Some will get, 2, 3, 4 genetically normal embryos. Some will get no genetically normal embryos. So it depends on what happens cycle to cycle. I would say the average number of cycles is probably somewhere between 1 and 2, but it's no more than that.
Next question is, do you recommend a varicocele procedure prior to IUI or IVF? So it depends. So I have seen so just so everybody knows what a varicocele is. Varicocele is veins in the testicle that are dilated. And in a testicle, because it's outside the man's body, the veins need to expand and contract to keep the temperature in the testicle at body temperature, because extremes of temperature will negatively impact sperm production. But if your veins are persistently dilated, they cannot contract to maintain heat, and therefore it has an adverse impact on sperm. So I have seen men do varicocele surgeries, and it's just been amazing that, wow, what a big improvement. But I've honestly also, more often than not, seen varicocele surgeries, and I haven't seen an improvement at all. So I think many factors go into play. If you're young, meaning you have time on your side, because when you do this varicocele surgery, you have to wait about 3 months, because it takes 3 months to synthesize sperm. You have to wait about 3 months to see the benefit, if any, from this surgery. So if you're young and you have time on your side, and there really are no other factors, then I think it may be worth it. But let's say you are much older, you have a tube that's already blocked, you've already done 5 IUIs without success. I'm not so sure varicocele surgery is really the best decision. Probably IVF, which will take care of the sperm issue, is probably your next best step.
Next question is, what's the process to find out if a couple is eligible? Well, everybody is eligible, so we won't turn away anybody, but we will certainly honestly educate them so that a couple who is looking to potentially enter a fertility treatment program needs to know if they have a good chance for success or not. And that boils down to completing these diagnostic tests we've been alluding to, and then regrouping with your physician to discuss those test results. And then once you know the position that you stand in, you make a decision on whether you want to proceed or not. But it would be pretty unusual for us to turn a couple down from doing treatment. We have more of an open door approach, that if a couple is adequately educated to where they stand, that then we're willing to take that chances with them. Along with that question is, when should a couple come in? And that depends on the age of the woman. So in women who are young, less than 35, sort of the formal definition of infertility is 1 year of unprotected intercourse. Once a woman gets to be 35 or older, that changes to 6 months of unprotected intercourse, because now after age 35, time becomes precious, and you don't want to be wasting that valuable time if there's something that we need to know about. And if you don't go through the diagnostic testing, you wouldn't know that they necessarily would have problems like that.
The next question is, what is the average cost for IUI and IVF? So we had discussed IVF cost, but I did not mention IUI cost, which is about $700 for a cycle meaning 1 month. Now, there is another treatment that's sort of a hybrid between IUI and IVF, which is that rather than using fertility pills like Clomid for an IUI, we use the IVF drugs for an IUI. But because you're using IVF drugs for an IUI, there's an increased cost because, number one, the IVF drugs, because they're powerful, we don't want you to have 8 eggs or 10 eggs ovulating at the same time, because you will then have the risk of becoming an octomom. So when you use IVF drugs, you do require more monitoring, which then increases the cost. And 2, the IVF drugs are also more expensive. So the cost of this hybrid model is about $1,500 versus just IUI with, for Clomid, let's say, is about $700.
Next question is, do you recommend a woman at age 39 do IUI or go right to IVF? And again, there'll be some independent variables depending upon that woman's circumstance. But I would say that more often than not, doing a few cycles of IUI is worth a try. It's the basics of the cost question that Dr. Park was just answering. It's so much less expensive than IVF. So trying IUI for a few cycles typically makes good sense, but don't stay there very long. You don't want to get stuck in a process where you're doing, 4, 5, 6 IUI cycles, and now that valuable time is slipping away. So I usually counsel women once they're over 37 to do 2, maybe at the very most 3 IUI cycles, and then we regroup, debrief what we might have learned, and then talk about going into IVF.
The next question is, can you insist on surgery for fallopian tubes, and what is the cost difference compared to IVF? So yes, if doing surgery really is most important, absolutely. But there are two, depending on the block, there are different types of surgeries. So the fallopian tube is like a sausage. And if the block is at the beginning of the tube, then the surgery consists of literally chiseling that opening. So you have to put a camera through the vagina and at the same time through your belly button. So in the proximal occlusion, you have to chisel the opening until you unblock the block, versus a distal occlusion called a hydrosalpinx is that the fluid enters the tube, but there's no exit. So it literally balloons up. In this surgery, you have to make, we call it a cruciate incision, like an X-shaped incision, and then you can actually even laser or sew the ends open so that they stay open. Keep in mind that with both of these, you have increased risk of reocclusion, and 2, a higher risk of what we call an ectopic pregnancy. Ectopic pregnancy means that the egg and the sperm combined, but rather than making its way through the tube to stick in the uterus, it got stuck in the tube. Well, what made it stick? Well, if the tube itself is diseased because of a past infection, there's a higher risk of ectopic. But even our surgeries will increase risk of ectopic because you have these microscopic scars left. Also keep in mind that if you had tied your tubes in the past, so let's say you had 2 kids in the past and you were 100% certain you weren't going to have any more kids. And then lo and behold, as life has it, you find another partner and you realize, I would love to have another child. To unblock those tubes through surgery, most insurances will not pay for that because you chose to have an elective surgery to block your tubes. So you will then have to pay to unblock it. The cost of that surgery to unblock it far exceeds the cost of an IVF cycle because you have to pay for cash a hospital in which you can do the surgery to unblock your tubes because you had electively chosen to ligate them. So in that scenario, most women will just go to IVF because it's actually cheaper than paying a hospital to use their operating room and all the services to unblock your tubes.
Next question is, what's more effective for gender selection, IUI or IVF? Well, it's actually a simple answer because IUI doesn't work. So the only real option for gender selection is to create embryos and do genetic testing of the embryos. There's an age-old sperm spinning procedure, it's called the Erickson method, that has been around since the 1960s, that was suggested as a technique to separate Y-bearing male-producing sperm from X-bearing female-producing sperm. But studies told us many years ago that that technology simply was ineffective. So doing IUIs with separated sperm is not a good option and is I think, a waste of time and money. So gender selection is really limited to IVF, where we get eggs, sperm, make embryos, and then do genetic testing of them. And we've talked about the cost of that already.
The next question, I looked back at your former questions, I'm just going to tie it together, was how many cycles does a 39-year-old need to do with normal sperm? But then you added, but with only 4 follicles. So when you give somebody IVF drugs, and you have a natural follicle count of 4, that means when we harvest, assuming all the follicles responded to the drugs, then we're going to get 4 eggs. But not all the eggs are mature enough to put sperm inside. So let's say of the 4, we have 3 eggs that are mature. So we do ICSI to fertilize. Well, the fertilization rate's not 100% with ICSI, even in a 25-year-old young woman. It's about 60 to 80%. So let's say we have 3 eggs and we fertilize with ICSI. So let's say we have 2 that fertilized. Then we have to grow to day 5. And when you have 2 embryos in a 39-year-old, there's a really good chance that none of them will make it to day 5, or maybe 1. And then what we don't know is if it's chromosomally normal. So if you know you have 4 follicles going in, I would strongly advise that you try a few cycles. And at our clinic, we do not, because as you may or may not know, we have to report all our success rates. So when we have patients who do 3, 4, 5, 6 cycles and they're all negative, they get reported as a negative outcome, even though there are no embryos to transfer. So, but at our clinic, we will not prevent you from doing treatment just to protect our success rates. If that is what you want, as long as it's been an informed discussion with your physician and you fully understand the low prognosis for success, we will absolutely support you. But you will reach a point where you will feel just exhausted, and not only financially, but just mentally and emotionally. And we will be very honest with you and tell you the success rates and then go over alternatives. So the long answer to your question is you can do as many cycles as you need to, but with every cycle, my advice would be that you sit down with your physician and discuss the past cycle, your plans for the next cycle, and the prognosis.
Next question is, what is the likelihood of getting multiple embryos and being able to freeze those embryos for the future? And the answer is quite likely, but very much age dependent. So Dr. Park had just illustrated what would maybe happen in a 39-year-old woman with 4 follicles, where she may not end up with any embryos to freeze. Contrast that to a younger woman with many more follicles, 8, 10, 12, 20 follicles. We're very much likely to get a good number of embryos and then a good number of blasts as embryos to freeze for the future. So age dependent, and something that we would be able to give you a pretty good idea about if you came in for an ultrasound to count your follicles and do some hormone testing.
Next question. When the sperm has been tested and 0% of the sperm is normally shaped, is IVF still an option? If so, what is the success rate? So the good news is IVF absolutely is very effective for sperm issues. And oftentimes when the semen analysis says 0% are normally shaped, keep in mind that that's just a sample, which is supposed to be a representation of the entire sample. But the truth is, when we do IVF and the embryologists look under the microscope, even though the semen analysis said 0%, they can usually find some normally shaped sperm. It's just a small minority, but they will look under that microscope for hours until they find the normally shaped sperm. But in addition, you may want to do further sperm testing. So for example, sperm DNA fragmentation test. And there are also some new sperm techniques. So there's something called Zymot, Z-Y-M-O-T, which is a device where you put sperm through one end, and this device helps to pull out sperm that has the best chance of success for fertilization. So I can tell you that in more cases than not, vast majority, even though there's allegedly 0% normally shaped sperm, we can find normally shaped sperm. And so once we do, it sort of becomes a moot point. So the success of IVF is once again dependent upon the age of the egg source.
Next question goes back to fallopian tubes. If one fallopian tube is open when a woman has a diagnostic test, what is the likelihood of it closing? Well, very, very small. So if the tube is open at the time of your hysterosalpingogram, There's nothing, unless there's some event that happens, infection, appendicitis, something like that, that fallopian tube is highly likely to just stay open. Now, what Dr. Park had alluded to in a conversation a few moments ago was surgical opening of fallopian tubes, and that's a different conversation. Because when you do surgical opening of fallopian tubes, the chances of them closing up again is actually quite high. And that is then reflected in the number of surgical procedures that are done in 2020 compared to maybe 20 years ago. Because now the success rate of IVF is just dramatically better than surgery.
What is the recommended sperm count for a frozen sperm donor to choose for IUI procedures? So I'm assuming you are purchasing the sperm from a sperm bank. So if you are, all that sperm has already been frozen, and then a test thaw was performed, meaning that when that gentleman went to donate, a sample was taken and thawed to see how well it would defrost. And only samples that had a good result were retained as a good sperm donor. So we want when we are getting ready to do the IUI, at the end of the processing, we want there to be 10 million moving sperm. And most sperm banks will guarantee this number, or they have a kind of program where they will refund or some kind of money back policy. If you're using a friend, then the semen analysis that your friend performs will give us an idea of how well the sperm will perform with an IUI. Because in general, normal semen analysis usually result in a pretty good sperm count at the end for an IUI.
Next is, what is the cost of a reciprocal IVF cycle? And just for the general audience, reciprocal IVF cycles are done when there are two women involved in creating a baby, where one woman provides eggs, sperm, and usually donor sperm to make embryos, and then the second woman receives the embryo to then get pregnant and carry that pregnancy to delivery. So reciprocal IVF is approximately the same cost as IVF that Dr. Park was talking about, but there's some extra things, so a little bit more involved, because now we have diagnostic testing for both partners, so probably an additional cost of maybe $3,000 or $4,000 at the most. So cost of an IVF is approximately $15,000. The cost of the added expense with reciprocal IVF, maybe a few $1,000s more than that.
Would a 34-year-old be considered older, or is it still a young age typically? Good question. So in the world of obstetrics, when you become pregnant and you're 35 and older, there's a term which I'm not fond of called geriatric pregnancy, right? So it implies that you're just like so old. But in our world, a 34-year-old is considered very young. Having said that, again, Dr. Kettel and I have been in practice for years, and we've seen our share of just surprise results. And I've seen some 34-year-olds that, talk to them, no significant medical history, and then their tests come back, and you're like, oh, wow, meaning that their egg numbers aren't great, their egg tests, the AMH and the FSH are not great. So the majority of 34-year-olds really are fine, but we don't really know that until you do your testing.
So next question is, what do you recommend for a 27-year-old to get pregnant before, I think it means before IVF? Can she get pregnant with twins? And I did want to take a moment to talk about twins, because there's a lot of women in the world, a lot of couples in the world that look at twins as an ideal outcome. Sometimes they're older and they want to be pregnant one time and sort of kind of one and done concept. But an understanding is required about the risk of twins, because not every twin pregnancy goes well, and complications are much more common in twin pregnancies than in singleton pregnancies. The biggest complication is early delivery, because every twin pregnancy is delivered early. And if you're delivered 2 to 3 weeks early, nobody cares, that's fine. But if the delivery happens 2 to 3 months early, that's a big deal. And there's going to be lifelong consequences for the children that are born from a premature delivery. So actually, we discourage twins. And if a patient actively wants to pursue twins, one of my jobs is to try to change her mind because of that additional risk.
And along the same twin lines, during IUI, can you guarantee twins or take fertility drugs to increase your chances of twins? So we cannot guarantee twins. I mean, even with IVF, if I put in 2 embryos, I can't guarantee twins. But absolutely, if you're doing an IUI and we give you fertility drugs, we can increase your chance for twins, but we cannot guarantee it.
Yeah, there's some questions here, but some of them we've already been addressed before. And what I wanted to address is, would you be able to explain the guarantee program? Because we have a financing program here at San Diego Fertility Center that is relatively unique in the world of fertility centers. We call it the Success Guarantee Plan. And it doesn't really guarantee success, but it's still a wonderful program, and I like it a lot. What the Success Guarantee Program basically represents is a bet on a set of embryos. So we're going to go get a set of embryos in an IVF cycle. And that may be 2 embryos, it may be 6 embryos, whatever it happens to be. But you now created a set of embryos. And now the bet is that you're going to become pregnant and deliver a baby from that set of embryos. And so off we go, transferring embryos. And we hope it works the first time, but it may not work the first time, and we may need to transfer a second time or a third, whatever it happens to be. But the bet is that you're going to get pregnant and carry that pregnancy all the way to the delivery of a baby. And if that happens, we win the bet and you keep the baby. So that's where we win the bet and the money stays with our program. If you go through the entire set of embryos and there's no pregnancy and there's no baby, then you're refunded your money, at least the lion's share of your money. So it really takes a lot of the financial stress off of getting into IVF, which is a treatment that has this very high success rate we've been talking about.
So I'm going through the questions because some of them are cost related, which we've gone over. Somebody asked, how do you contact your clinic from the time you submit the new patient paperwork? So the email right here, frontoffice@scfertility.com, is the email you would email if you're interested in scheduling a consultation. And there's then paperwork you have to complete, medical forms, registration forms, and once they receive that paperwork, they will then schedule you with the next available physician. And the question said to qualify, I'm not sure if it meant qualifying for new patient consultation or for treatment, but we don't selectively choose our patients. If you would like to come speak with us to be educated, to have your questions answered, you don't qualify for that, by all means, submit your paperwork.
So Dr. Park just talked about scheduling an appointment. Next question is, have you seen benefits from acupuncture? And acupuncture is a wonderful tool. I think it's a particularly wonderful tool for stress reduction. So infertility is a stressful situation. People have tried to measure stress. It's very difficult to measure stress, but many experts have suggested that infertility is one of the more stressful events that can happen in a couple's life together. And I think acupuncture is one of the more effective ways to help manage that stress. You know, the acupuncturists look at the world much differently than, you know, traditional Western medical providers like Dr. Park and I. And I'm not going to try to go into the rationale and their beliefs in their Eastern Chinese medical procedures. But I like to have patients who are considering acupuncture go to a session with an acupuncturist and kind of take a litmus test of that session and see how they feel. Because when an acupuncture session takes place, you typically go into a treatment room, the lights are turned out, they put on some interesting music, and they put needles in you. And for some people, that's not a relaxing event. Other people go through an acupuncture session and they walk out and they just feel wonderful. So if you're one of those that feel wonderful after an acupuncture session, I think it's probably a good thing for you to do. And it's going to help you manage the stressful events that go along with a fertility journey.
How much does it cost to freeze eggs and how long can they be frozen for? So that's a great question. So egg freezing is such an important treatment to offer patients. So who would freeze their eggs? So maybe you are a woman who hasn't found the right partner. Maybe you have this career set in mind that just requires just a lot of years of either schooling or training or a lot of traveling, but just now is just not the time to have a child. And as you've heard through the evening from both Dr. Kettel and myself, because there's a question that said, what are our names? Because the beginning slide we had posted it, but we forgot to post it afterwards, but Dr. Michael Kettel and Dr. Susanna Park. So as we've alluded to through this talk is the older a woman gets, the less likely those eggs are going to be good to result in a child. So egg freezing means that when you are most fertile, and you can do this at any age, but in the perfect world, you really want to do it when you're in your late 20s, early 30s. You undergo the IVF treatment, you take the drugs, we put you to sleep, we take the eggs out, but we don't fertilize. We freeze them just as eggs. And the cost of this is about $9,000. And there is an annual storage fee, which is $500 for the year. And those eggs, just like embryos, can be frozen indefinitely without a decrease in quality. Now, one difference, though, between frozen eggs versus embryos is that a frozen egg is one cell, whereas an embryo is about 100 to 200 cells. So frozen eggs may not tolerate the freeze and thaw as well as that of an embryo because embryo has many more cells, but it's still rather successful. The success rate from thawing on average is about 70 to 80%. Last year, when we defrosted our eggs, we did the statistics, and it was a 93% survival rate. So it fares rather well in our lab.
So then, last question, I'm going to combine a couple of them here, and this is more revolving around the logistics of getting your treatment started here, and what happens if you've had some initial testing or treatment with another clinic. So Dr. Park had walked you through the process of scheduling that initial appointment. There's an email in front of you that can help you with that. And we certainly do accept testing that's been done at other clinics. So what would happen in your initial consultation with us here, oh, by the way, that I think it's $275, is that you would come in, meet with the physician, have an ultrasound done, all included in that one fee. And then depending upon the individual circumstances, recommendations made for next steps. But we're not going to repeat testing that's already been done. So if you've already had a semen analysis at a different clinic, or hormone testing at a different clinic, or a hysterosalpingogram of your tubes at a different clinic, that's fine. We're not going to make you repeat those. So we're going to try to keep the costs down as much as we can. Then the last part of that question was, if you do choose to schedule a consultation, can you select your physician? And the answer is, of course you can. There are 5 of us here. We're all board certified, wonderfully trained, slightly different backgrounds, but very similar at the end of it all. Some of my favorite people on the planet are my partners. So you'll be in great hands no matter who you choose.
Another question is, what is the lowest number of follicles required for IVF? So again, everybody practices differently, but at San Diego Fertility Center, we will not turn a patient away to protect our statistics. It's unethical, and it's not the way we practice medicine. So there is no minimum number of follicles. I mean, obviously, if there are no follicles growing, there's no retrieval, but even if there's only one follicle, we discuss with you the pros and the cons of moving forward. And as long as it's an informed decision, and if you say, you know, this is the best I can do, I only have one, I'd like to move forward, we will support you. So, you know, when you're doing this for years, you see your share of miracles. And I have had a patient who had one follicle growing, and her stimulation went very long, and we had multiple discussions about possibly canceling. And she insisted, and I said, okay. And we got one egg, and it fertilized, and it resulted in her son. And I said to her, you are one of my miracle patients. And so we've all learned that, we don't always have the right answers. And sometimes the patients just feel that they just need that chance. We are not going to say no, but we are going to be honest and discuss the pros and cons with you. But at the end of the day, we will support your informed decision.
So I think that was a wonderful webinar. For those of you who stuck through to the end, I hope we adequately explained the process of fertility treatment and contrasted the differences between IUIs and IVF. We've talked about how to get started in treatment by scheduling a new patient appointment through that email on your slide screen. It's been a wonderful evening to spend together with you. I will then sign off here and hope to see you here in the center soon.
Thank you. Good night.
Good night.